So, okay, I'm going to just go over a few other, that was so that you could do most of the work for me, so thank you. But I was going to give a few little recaps from yesterday before going into the panel this morning. So yesterday we started with a panel on approaches with a kind of a harm reduction frame in mind, and we had Hazel Booth, nurse practitioner, give us an overview of trauma-informed care from her experience and she discussed various levels of prevention and the importance of recognizing primary, secondary, tertiary prevention. Dr. Leo Elwell showed us his view from the front line as an addiction specialist, psychiatrist, with comments on the connection between trauma and addictions. Gave comments on the patchiness of current services and gaps in providing comprehensive service, including opioid substitution therapy. Also talked about the taking advantage of the moments when people with substance use are there and have connections, taking advantage of those moments when they are connected to strength factors in their lives, that really taking advantage of when they're ready and when they're connected in order to have them taking advantage of treatment opportunities. And he also talked about the importance of screening, that when you're with clients, that we all get better at screening for substance use disorders, including alcohol, opioids, mental illness, there's an advantage of using common tools and being adept at using those tools. Karen Niclot joined us next as someone who had suffered from addiction herself, and she introduced us to her very powerful video describing what she lost as an addict, but the life that she regained as she recovered. And Louise Hardy, as was mentioned, gave us a very powerful look at the approach to the trauma-informed client, the need for respecting and embracing and recognizing the silence that is often there, and the need to use that to gain trust slowly. She talked also on the physiological level, the epigenetics and cellular level changes that might explain the intergenerational effects of trauma and help us understand its broad impact. Dr. Sharon Lazeo, who's here with us today, the program lead for the Taiga Referred Care Clinic, gave us a history of the clinic from its evolution, from its humble beginnings, and a description of its current range of service to individuals with mental health and addiction problems, including the use of Suboxone for opioid substitution and their experience with it to date. And they're piloting a kind of a consultative service for helping patients of other primary care physicians start people on Suboxone. So really a kind of an ever-expanding role of this clinic and becoming a core of expertise. And then there were some morning discussion groups, and we talked a lot about transitions as being difficult and vulnerable areas that need more attention. That means people who are transitioning from corrections to the community, from the hospital to the community, and all of those transitions in and out of social services, in and out of justice system, in and out of hospital, ADS services, et cetera, that we need to really more actively and manage in a more coordinated way. We talked a lot about Suboxone, access to Suboxone. We talked about addictions as a polysubstance. You know, when we talk about opioids, so often we're not just talking about people who have these pure opioid addictions. They're polysubstance problems very often, and we need to kind of be cognizant of that too. And we talked a lot about need for coordination, and we're going to talk more about that today. May's Kat's sessions with us, talking, and May talked about her experience working with traumatized communities in Northern Ontario, and again, some of you may have heard her on the radio as well this morning. high suicide rates, high rates of sexual predation, along with addiction, all linked to intergenerational trauma and combined with some of those low socioeconomic prospects and poverty, and resulting in high rates of oxycodone addiction. And May talked about how agreements with community leaders were established to try Suboxone, the compromises that were made in order to commence Suboxone, and then the trust that was gradually gained, the importance of winning over skeptics and naysayers, and showing results with practice-based evidence in addition to the existing literature. And she was able to demonstrate success in pilot projects that then led to larger support to continue and expand. And she was able to document a series of successes and reduce suicides, increased activities on the land, sales at stores increasing, school attendance increasing, kids happier, lots of these extensive ramifications. Lessons that it can be done if the need is there and if the community supports you, that you can't separate addictions from its determinants, whether trauma, socioeconomics, the land. The second session was more focused on the high school-based Suboxone program, and how similar results were gained with high school youth in the Thunder Bay, who started with addiction rates at 43%. But as kids were successfully treated and brought their own peers and supported their own peers, those addiction rates plummeted. It was the kids who really triggered the community programs to say, if you want to kind of stop this tide of kids coming in who are addicted, you need to get out in the communities. That's the community wellness program. And then the kids were starting to graduate. Kids became more active, and of course all of those effects of the success in youth. Not to say that the work is over. It's still ongoing work. There's still people on wait lists, but certainly inspiring successes demonstrated from May's and her co-workers that they've been able to demonstrate. We had a simultaneous session talking about the regulatory environment for nurses in this field, and I wasn't part of that. I don't have notes from that, but I don't know if anyone wants to give a capsule from that session. Kathy, were you involved, or Sarah? Any key point that we should take from that session? Okay, well that will certainly be reflected in the notes and from that session as well. And then in the afternoon, we had a more discussion group about to do with the groundwork that May had laid with the description of the Northern Ontario experience. So we had a couple of different groups focused on youth, one on prevention and one on treatment. And so some of the key factors in prevention that were some of the points from the table discussions, and this is not comprehensive or necessarily even the most important points, but some of the themes I picked up. People talked about school-based education and the importance of doing better there. The importance of parental education, including helping parents speak with their adolescent, their children, and especially their adolescent and teen children. The importance of peer-to-peer, using again, the strength of youth and the trust that youth have with each other to take advantage of peer-to-peer mentoring. Again, importance of determinants, physical activity, culture, encouraging those sort of broader strengthening activities that keep kids focused, keep kids from embarking on more destructive behavioral patterns. In the treatment group, some of the ideas, one of the ideas was the use of lay people, especially in communities. It's an opportunity to look at people in communities who may have leadership roles, who may have experience, but they're not formal health professionals, and they can be they can assist in treatment, and and some of the themes of, have the idea of developing a kind of a consistent way of managing addictions and opioid substitution, but recognizing rural-urban differences. So we may have, you may have kind of similar goals and a similar overall approach, but you need flexibility to recognize that each community is different. And especially harnessing the strengths that each community has to offer. Communities often have unique strengths and connections. They have traditional practices that can be that can be lessons for other communities, and can also help to inform the urban approach here in Whitehorse. So those are some of the themes, and I think hopefully that will help kind of generate some of the flavor from yesterday into to infuse into what we discussed today. So I think without further ado, do I get to bring Amy up to moderate? Hi, Amy. To moderate the panel for this morning. Thank you.
All right, good morning, everyone. My name is Amy Fry. I'm a pharmacist here in Whitehorse. If I could have all the panelists please come up and join me at the front. So we have 4 panelists this morning, and they all practice non-drug therapies. So I know that's not my area of expertise, so I'm happy to host this session. Great, thank you very much. So just a brief intro. We are going to discuss non-pharmacologic management for acute and chronic pain this morning. And these hands-on or psychological approaches will hopefully decrease or potentially, ideally, eliminate the need to use opioids to treat pain. So our panelists will discuss what non-drug interventions they use in their practices and how patients in both Whitehorse as well as the communities can access these services, which I think we may hear about some barriers and challenges there. And we do realize this panel certainly doesn't encompass all non-drug modalities to treat pain, but I think this is a good start to get us thinking about how we can collaborate with other allied health practitioners to treat pain. So what we're going to do is each panelist will have 10 minutes to tell us, unfortunately quickly, about their day-to-day and how they treat pain. And then after that, we're going to open it up to a question and answer period. So we know that every day, most of us in here help patients cope with their pain, get through their day-to-day. Even we have patients, some of you in here bring your patients every day to our pharmacy to pick up their medications. So we look forward to hearing what you have to say as well and sharing your successes and challenges and how you help patients in non-medicinal ways to treat their pain. So first up, we have Dr. Jonathan Hawkins. So Dr. Hawkins is a chiropractor at Chilkoot Chiropractic. In his practice, he treats a diverse number of medical conditions, and he's also going to point out how it's not only spine and back pain that neck and back pain that he's treating, and he also practices acupuncture. He's a recent graduate in 2015, and during his internship year, he also spent 6 months practicing at a First Nations health clinic in Toronto. So please welcome Dr. Hawkins.
Thank you very much for having me. Just wait for the presentation to pop up here. Perfect. Okay, so first off, I'd like to go over what chiropractors do. Perception of chiropractors solely as practitioners who use spinal manipulation or crack patients' backs is slightly incorrect and outdated. So while this has been true in the past and still is present in some of the more philosophically based chiropractors, the newer, more progressive chiropractors are well versed in treating acute and chronic neuromuscular pain using a biopsychosocial model. Because our education includes orthopedic and diagnostic assessments for the entire body, we commonly treat conditions outside of the spine, such as plantar fasciitis, lateral epicondylitis, patellofemoral pain syndrome, ankle sprains, etc., etc. Although, for the general public and for most healthcare practitioners, we are most well known for treating the spine. So, as it was brought up many times yesterday, starting with Hazel Booth and then continued on with a few different presenters, Psychosocial stressors are very important to assess in the patients that we see. Unfortunately, many manual therapists and general practitioners weigh too heavily on the biological causes of pain, such as hip arthritis, muscle strain, disc irritation, when treating musculoskeletal conditions. This means that they neglect other factors that play into a patient's pain perception, such as the psychological, behavioral, or social components. As I will discuss later, these yellow flags are being recognized as one of the main reasons why acute low back pain becomes chronic. So trying to identify and change these risk factors before they become entrenched in the patient is very important. Now I'm going to delve into more of the opioid side of things. So we didn't really get a lot of stats yesterday, but currently Canada is the world's second highest per capita consumer of opioid pain relievers, right behind the US. And as I've been asked quite a few times before this presentation started, how exactly do chiropractors relate to this? Well, we know from insurance companies that over 50% of chronic opioid users report back pain. At a pain management clinic in Hamilton, they found that 65% of people who are receiving long-term opioid therapy for non-cancer pain came in with chronic low back pain. And as the #1 reason people visit chiropractors is due to low back pain, we are well positioned to care for these patients. So there's an interesting study done in 2016 in the US looking at Medicare data. And what they found was there was an inverse relationship between regional usage rates for chiropractic services and patients receiving opioid prescriptions. In Ontario, chiropractors have become integrated into the mainstream medical system and now can be found in many hospitals. This is because chiropractors have been found to be a cost-effective way of managing low back pain. In Ontario, they've done pilot projects which include chiropractors as part of the family health teams. What they found was when there was a chiropractic medical collaboration, narcotics were prescribed to 14% of patients who were referred to chiropractic care, compared to 43% of patients who were not referred. Furthermore, patients referred for chiropractic care had 25% fewer physician visits and 25% fewer imaging requests than those who were not referred. So how do we help? Many different pathways, in my opinion. The most important ones are patient education, self-management strategies, and lifestyle modifications. We're also well known for doing manual therapy, so that includes soft tissue therapy, joint mobilizations, joint manipulations, spinal manipulations, as well as prescribing therapeutic exercise. One of the benefits of chiropractic sessions is the increased amount of face time that we spend with patients. So initial visits are usually an hour in length, and subsequent visits anywhere from 15 to 45 minutes. And that, as well as our hands-on care. So this allows us to build a trusting relationship or rapport with the patients, which makes them more comfortable to discuss such topics such as their psychosocial aspects, which may not be discussed in a shorter visit if you are just a quick little in and out with your medical doctor. So, very recently, there have been lots of guidelines published to support the use of chiropractic care and spinal manipulation. This is not a complete list, but some of the larger ones include the new Canadian Opioid Guideline, which was released May 8th of this year, the NICE Guidelines, or the National Institute for Health and Clinical Excellence, the American College of Physicians, the American Pain Society, the European Spine Journal Guidelines, the North American Spine Society Guidelines, as well as the AHRQ, or the Agency for Healthcare Research and Quality, which all support chiropractic treatment as a first-line option for conservative care. If you haven't had a chance to go through the new Canadian Opioid Guidelines, I've highlighted a couple of their recommendations. So their first recommendation states that when considering therapy for patients with chronic non-cancer pain, they recommend optimization of non-opioid pharmacotherapy and non-pharmacological therapy, rather than a trial of opioids. Their other recommendation, there's a few in between there, but then the 10th recommendation that they add also states that a formal multidisciplinary program should be started, and if not accessible, a coordinated multidisciplinary program that includes several healthcare professionals. There's an extensive list at the bottom there, which does include chiropractors as well. So currently, we know that the evidence shows that spinal manipulation is at least as effective, if not more effective, than conventional drug approaches, which is why it's been included in all these guidelines. So low back pain, there's a lifetime prevalence of 60 to 70% in the industrialized countries, and a one-year prevalence of anywhere between 15 to 45%. It's been described as a normal occurrence, and most people are going to experience it at some point in their lives. So the issue becomes not so much preventing an acute flare-up of low back pain, but how do we make sure that this acute episode of low back pain does not become chronic? A lot of the understanding that we currently have of how acute low back pain becomes chronic has to do with the overlay of psychosocial risk factors, or yellow flags. So assessing of psychosocial risk factors has been included in a lot of the back pain guidelines, but in my experience, it's not commonly addressed. Patients are more likely to be sent for an MRI, which feeds into patients' fears, rather than being properly assessed for their yellow flags. So what are some of these yellow flags that I've been talking about? Patients' attitudes and beliefs about back pain. If they're believing that pain is harmful or disabling, this is going to result in fear avoidance behavior, which is going to result in guarding and fear of movement. Other things could include catastrophizing or a passive attitude to rehabilitation. So the emphasis by healthcare practitioners needs to be on active care. Patients' behaviors, report of extremely high intensity of pain. So if someone's coming into your office with pain that's 12 out of 10, but they seem to be strolling in pretty fine, then you've probably got a risk factor there. High intake of alcohol or other substances, so that increases with the onset of the back pain, as well as smoking. Compensation issues, so there's a lack of financial incentive to return to work. Diagnosis and treatment. This is the one I've found, in my opinion, shows up quite a bit, is when patients experience back pain, they get conflicting diagnoses if they're going to see a chiropractor or a medical doctor or a physio. So there needs to be better communication or a common language between all of our professions and better interprofessional communication. And diagnostic language that we use with patients can lead to catastrophizing and fear. Other risk factors include emotions, so if the patient's depressed, if they're stressed, if they feel useless or not needed. Family issues, so if they have an overprotective spouse, usually well-intentioned, but this can increase their fear of harm or encourage catastrophizing, or if their spouse takes over their normal tasks. And then work, so if they have job dissatisfaction, if they have a poor relationship with their peers or supervisors, or if they have belief that their work is harmful or do damage. So all of these are just a few of the many psychosocial risk factors that we need to be screening for. And what can we do about yellow flags? So obviously, as I previously mentioned, just our communication with patients is a large part of that, but also decreasing the fear avoidance behavior. Patients should be gradually and incrementally exposed to what they perceive to be painful activities. So if we can guide our patients and teach them that certain movements that they're doing are not actually as painful as they perceive them to be, they're going to get better quicker. Part of this process includes therapy of graded exposure. On top of that, reassurance and education are key. In addition, it's good to educate patients that low back pain tends to recur. So throughout their lifetime, it is likely that they are going to have another flare-up. So rather than build on the expectation that back pain can be fixed or cured, they need to be not disheartened when this pops up again because they have the tools to manage it. And then my last slide here has to do with some of the barriers that patients face. So obviously, access to care in communities is a big problem. Currently, there's only 4 practicing chiropractors for the entire territory. And while this is not even enough to support Whitehorse, let alone the communities. If a patient does come in from the communities, it is possible that we may only see them once. So a lot of the time during our initial assessment, we have to spend a lot of time on education and self-management strategies that they can do on their own. Unfortunately, doing that on your initial intake visit, you might not have built up the appropriate trust, so you might not be able to get to all of those psychosocial aspects that have been previously discussed. The other barriers that patients face is cost. So if people do not have insurance, they have to pay out of pocket. This makes it hard for some people to weigh the benefits of going to multiple chiropractic or physio sessions when they know they can go and get a bottle of prescription pain, which is a lot easier for them to do. On top of that, my last point here is just interprofessional collaboration and communication. So a large aspect that needs to be broken down. Thank you very much.
All right, that was great. Thank you very much. So our next presenter is Kristy Lerch. Kristy is a physiotherapist and owner of Whitehorse Physiotherapy. She has done extensive postgraduate work in orthopedic diagnoses and treatment, as well as specialized training in various pain syndromes of the spine, neck, and hip, including as well as headache, TMJ, and then pelvic health as well. So very diverse background. She is also available to provide acupuncture. So Kristy will discuss how physiotherapy can be used as an alternative to opioids in the treatment of pain.
Okay, thank you for having me. I'm very happy to be here, actually. It's nice to have the discussion, and it's really nice to have all of us, because I think we didn't talk to each other, of course, because we don't talk to each other, right? So we didn't talk to each other before we did this, but I think we're actually going to, by serendipity, give you a really good presentation. So thank you, Jonathan, for that aspect, because I didn't talk about any of that stuff, so that's great. So I get nervous when I talk in front of you, so my voice is going to shake, and hopefully by halfway through I'll calm down a little bit. So I think the first thing to remember is opioids do have a role in treating chronic pain. So we often work very closely with our physician colleagues to manage that aspect of it, because that's not our role. But opioids can help a lot to decrease the pain sensitivity in people, so we can actually go in and do our treatment. So it's just important to remember that they do have a role. And what we're all, I think, looking for is we're looking for giving someone the right treatment to the right person for the right reason. And so that involves a lot of different multifactorial things. I'm just going to talk about a very small aspect of the treatment of chronic pain, but it's really important to remember, as Jonathan said, that it needs to be a multidisciplinary approach. So where opioids can be very effective is to break that cycle of pain in terms of the pain, spasm, pain cycle. So somebody gets pain, they get anxious, they get more muscle guarding, they get more pain. It's sometimes we refer people back to the doctor for pain control because that medication can interrupt that cycle and allow the sensitivity to go down so we can actually intervene. I should look at my notes. So it's really important, I think. I think sometimes what happens is we, I think, forget the basics sometimes as physios. And I think we have to remember that we have to address the dysfunction in the joint. The muscle and the nerve have to be addressed. We can't simply just impose exercise on a dysfunctional nerve, dysfunctional joint or muscle and expect that someone's going to get better. And I said before exercise here, but really it should be in conjunction with exercise. So some of these things aren't seen on imaging, so it's sometimes difficult to diagnose these things. So you can't see, if a joint is stuck in flexion or extension, it's not gliding and it's causing pain, you can't see that on an x-ray. Same thing with myofascial trigger points in a muscle, you can't see that on any imaging. And abnormal movement, you can't see it. So it's sometimes hard you have these people with these pain conditions, and you'll get these normal imaging results, and it makes it difficult to understand what's going on. So often musculoskeletal dysfunctions can sometimes look like something else and get missed, when they persist and are not addressed, an acute condition can become chronic. You get fibrotic changes in the joint occurring over time. You get muscle tightening and shortening over time. And sometimes this pain can persist for months or even years before it actually, you can figure it out. And lots of times patients will go through a lot of different investigations and different kinds of treatments that don't work. And so it's frustrating. So just a couple examples, quick examples of things that look like something else that can be joint or muscle dysfunction. So this used to be called T4 syndrome. I don't like using the word syndrome because it makes it sound like it's really bad. It's not. It's just simply what happens when you have restriction in your upper thoracic joints, and it's typically around T3, 4. People can get pain that mimics cardiac pain. So pain when they're taking a deep breath, pain radiating down their arm, pain in their back, and some people will go to the ER and think that they actually are having a heart attack. So I'm just presenting this as something that's a joint dysfunction that can present and look like something else. And it just makes some of these things confusing when you're looking at treating them. Another one that's confusing is myofascial pain. So this is confusing because the pain is often distant from the site of the problem or the trigger point in the muscle. And again, it often looks like something else. Often these dysfunctions are missed and treated as something else. And it's confusing. It's confusing for physios, chiros that miss it, because we all do miss things, doctors. It's confusing for the patient because we don't really know what's going on. So for example, this is a trigger point in a small muscle called your subclavius, and it's here. But this looks like, to us as medical practitioners, that it could be something coming from the neck, something coming from a disc. And so if I go ahead and treat that and it doesn't get better, it can get confusing. And then I'm going to go and order an MRI. The MRI is going to come back normal. And it's just very frustrating when these things get missed for patients and also for health practitioners. This is just some other examples of how things can get even more confusing. So these are your lateral abdominal muscles. And so they can cause, the one down and below can cause bladder pain, diarrhea. The one up above can cause reflux and heartburn. So something that's muscular looks like something that's organic or an organ type of problem. So these things can be confusing. Same thing with back pain. This is the referral from your hip flexor, a muscle in the front of your hip that can refer pain to your back. Another one is just your abdominal rectus abdominis is an abdominal muscle in the front, again referring pain to your back. And we do pelvic floor treatment. We treat a lot of chronic pain at our clinic. So this is just another example of how the pelvic floor muscles can refer pain to an area in the pelvic floor that looks like something else. Could look like any kind of condition that's in that area of the structures that people aren't thinking that's muscular. And then headache pain. This muscle, sternocleidomastoid, can also cause nausea, dizziness. We treat it a lot as well. So again, a muscle is causing a problem that looks like something else. I'm kind of rushing because I don't want to be behind. So I just bring those up as examples of how when these things get missed, those muscles can shorten and tighten to the point they get actually numb. So when they come to the clinic, I can go in and I feel that muscle and it's really tight. And it's like, sometimes it feels like a block of wood, it's so tight. And they don't even feel pain when I touch it, but all the pain is distant from the site. And so it just brings things up that some of these things, when they become missed, they become chronic. When we start to treat them, we can reduce the pain. When someone has this type of pain, they usually are on some kind of medication long-term that they've been put on just because we have missed it or we just didn't understand it. So in terms of treating these things, we do a lot of myofascial release, cupping, IMS. I'll be fast. IMS works very well to release these tight muscles, especially chronic. And manual therapy, we do spinal manipulation at our clinic to restore the normal joint and nerve motion, appropriate exercises, and importantly, lifestyle habits, education, activity, modification. So my take-home message is medications have a valuable role in temporary breaking the pain, spasm, pain cycle, so physio or chiropractic or other manual therapy can be effective. A physiotherapy assessment or a chiropractic assessment can identify acute or chronic pain caused by muscle, joint, or nerve dysfunction that can't be seen on imaging and isn't resolving with standard treatment. So I think that it's important, even if they just got assessed by someone who's familiar with these things, sometimes it's worth it. If you don't, most of the time it's worth it, because if it's not there, then you haven't really lost anything. But if it is there, it could be a way to get them out of that chronic pain. And just that there's proven cost-effective physio treatments that can reduce or resolve chronic pain. Thank you.
Thank you very much. That was awesome. Drugs are bad, aren't they? I'm just kidding. I wouldn't have a job, would I? Okay, so our next presenter is Leslie Van Tongeren. So Leslie is the clinical leader for therapy services at the Yukon Hospital Corporation. So although most recently in a leadership role, Leslie has 17 years experience working with patients with a variety of different pain issues, from complex trauma and catastrophic injury to kind of more immediate post-op pain and things like that. So one of her jobs in her previous role was actually to develop more long-term strategies to help patients deal with their chronic pain in non-medicinal ways. So if Leslie could join us.
Hello. So as she said, my name is Leslie Van Tongeren. I decided not to do a formal presentation and really just have a talk about what it is that we have in our program and what are the limitations, what are the things that work well, what are the things that don't work well, and sort of hope that I can get from you what it is that we can change about our program to better manage patients with addictions. Can everybody hear me okay? Okay. So I'm the clinical leader for Yukon Hospital Corp Therapy Services, which is essentially 3 hospitals, Dawson, Watson, and Whitehorse. We do not do any visits outside of the hospital. We are inpatient and outpatient services in the hospital only. Most of our therapists are working out of Whitehorse, and we do both occupational therapy and physiotherapy visits to Watson and Dawson every 3 months, so for a week. So these are not huge amounts of service going out to the communities. We do some follow-up with telehealth if we've gone and seen the patient. So we do offer follow-up that way, but certainly not assessments. So this is sort of what we offer. It's physiotherapy and occupational therapy are the professionals that we employ. So in terms of what the demand and how I fit into this and whether or not I even fit into this was the original question, is that we are getting approximately 200, slightly over about 210 referrals every month. And about 25% of those, or 50 out of 200, are for chronic pain. So when I arrived in Whitehorse, so as she mentioned, my background, I worked in Vancouver and I ran a consultation company for patients who had undergone catastrophic injuries that we're going to be looking at, where we need to assess future cost of care, what their pain management strategy was going to be long-term, amputation, spinal cord injury, fairly significant injuries and change to life. And so when I moved here, mainly based on my love of canoeing, we looked at, okay, so here's therapies, we don't know anything about the Yukon, and it's, a learning experience for sure in terms of it's a different population, and how do we serve this community? And so when we looked at it, when I arrived, this was 2 years ago, June 1st, 2015, we had a wait list of 647 people. We weren't seeing any chronic pain patients. We hadn't booked a chronic pain patient in 2 years because in a triaging system, we triaged the most acute patients. So we were seeing almost entirely post-operative patients or patients who had fractures, something major that needed to be seen. And so, for better or for worse, what we put in place was a visit maximum, so that way, when patients came in for significant postoperative issues, they weren't coming for 100 visits, and meanwhile, our chronic patients getting nothing. And so, I think we're still in a process of evaluating whether or not that was a good idea, a bad idea. Certainly, there are people getting care that weren't getting care before, and I think that's huge. The chronic pain issue is massive. I mean, we all know that 20% of Canadians suffer from chronic pain. We are a publicly funded program, so nobody pays for our services, which is a huge bonus. We're also fairly rare in the fact that the hospital here doesn't have a criteria that you have to meet. So when I've worked in other hospitals like St. Paul's, the outpatient program was simply a post-operative rehab for their surgeons. So you had to have surgery at their hospital with their surgeons, and then you had follow-up by a physiotherapist in their outpatient clinic. If you had chronic pain, you could go to the pain program, which is a whole other specific to St. Paul's program. But if you had low back pain, you didn't meet the criteria. And so here, it's a unique scenario in that we can actually send anyone to our program, which is phenomenal, but also from a management point of view, very difficult to manage the demand. And so when you have no criteria that you have to meet. And so one of my fears in coming and talking today was, oh my goodness, if I tell more people that there's no criteria, what am I going to do? And there's going to be 400 referrals next month, and I'm going to have to manage this, and this is a nightmare. So really don't send anyone to me. So that's quite a genuine fear, to be honest. So that's what we are. We're OTs and PTs, and a huge portion of our role is chronic pain. So what do we offer? So what we offer really depends on the patient. What's wrong with the patient? What's the part of the body? So some of the things that we offer are, the classic strengthening, stretching, but hot and cold and contrast baths and hydrotherapy, TENS, mirror therapy, vibration, pacing strategies, desensitization, traction. I mean, the list goes on and on. And so I have 10 minutes to talk about the evidence to support non-pharmacological interventions for chronic pain. And what's fascinating, if you do a review on all these huge amount of, the number is endless on what you could possibly use as an intervention. So if you just we're just going to take one example of a TENS machine. So for anyone who's not familiar with a TENS machine, it's you put electrodes on a patient's skin, you use a battery-operated device that creates a electrical current that is transcutaneous, and it stimulates the nerves. And in my experience, some patients with quite severe pain will start crying because it's the first time they felt something else in that area. And the benefits are very different depending on what the issue is, who the patient is, but it can have quite a tremendous effect in especially acute pain, but also chronic pain if it's used properly. So if you look at the evidence for TENS, the evidence is completely different depending on what is the diagnosis that you're treating, and what is even the part of the body. So if you're using TENS for osteoarthritis, or you're using it for phantom pain, or you're using it for post-operative pain, or pain during pregnancy or during labor, the evidence is completely different depending on what you're treating. And then on top of it, if you just take something like osteoarthritis, the evidence is completely different depending on what part of the body you're treating. So there's high evidence for neck osteoarthritis and very low support for evidence on back osteoarthritis. So this is complicated. It's incredibly complicated. And what I learned while working at St. Paul's was we had a woman who worked with the pain clinic in St. Paul's, which is phenomenal, and it's a huge wait list. This is very, you have to devote your career to this. And in Whitehorse, one of the challenges is that we're generalists. We are treating everything, and chronic pain is one of many things. And even within chronic pain, like I mentioned, there are numerous different types of chronic pain. So just to give you an example, and I wrote down, this was my day. So I do some clinical work, especially during periods of, you know, when we have spring break or Christmas time, summertime, and we get short-staffed, and I'll work entirely clinical. So this was one day at WGH Therapies, and I'm a physiotherapist. So 8 a.m., we took a 3/4 cast off on a patient who had a distal rupture of their distal bicep tendon. So it was a rupture repair, removed the 3/4 cast, put a hinged brace on him, and locked the hinge brace properly so that he had the right range of motion for that, for post-op day 8. That's 8 a.m. 8:30, we debrided necrotic skin from a frostbite patient after using a whirlpool. At 9 a.m., I did a discharge assessment on a patient with a brain injury who was going back to a remote community with no support. At 10 a.m., we made recommendations to an employer on returning to work after multiple fractures in a snowmobile accident. And at 11 a.m., we treated phantom pain in a amputee. So generalism is both wonderful for the clinician because you're always fascinated by what you see and you're always learning. But are we doing a great job at treating chronic pain? And from an educator perspective, you know, when I'm trying to make sure that staff are competent and we're putting on cervical spine braces on patients with C-spine fractures, I go, where do I spend my time now? I'm training these staff. I've got a high-risk activity, or we can talk about complex regional pain syndrome, right? And not that we're not doing that, don't get me wrong, but it's a challenge for sure. And so, you know, when looking at, okay, how do we improve access to chronic pain in the Yukon? I've been here for 2 years, so, you know, you're going to have to be the judge of whether or not you want to even listen to these thoughts. But you know, what I saw when I got here was that chronic condition funding was temporary when I got here, right? So it was year to year. The funding was never really a sure thing, and so it takes time to develop these programs. So then it was really exciting when the funding became more permanent. And we actually are quite lucky to have people like Melissa Leluc, who is passionate about this, and I think it's an opportunity to take advantage of people like that in a positive way. That sounded horrible, didn't it? So what I mean by that is, you know, these people need to be passionate about this and devoted to it and devote their career to it, and we need to be committed to it. And so when I see the funding go permanent, it was very exciting, and then the funding became about COPD and diabetes. And when we look at the numbers of people suffering from chronic pain exceeds this. It exceeds the numbers for COPD, it exceeds the numbers for diabetes. And so exciting to have chronic funding become permanent, very narrow focus. And I can appreciate from a leader standpoint that you don't want to overextend yourself. And it becomes very difficult when you're putting in a new program, you don't want to offer too much and then sort of not be able to give good quality. So I think we need to ask ourselves, if 20% of our population has experienced chronic pain, do we want to commit to this? And whether you use my program doesn't matter to me. I think we're happy. I'd love to see it anywhere, funded permanently, somebody who's passionate about it, who's going to spend 30 years in it. It's great. Hope that was helpful.
That's great. All right. Thank you, Leslie. So our last presenter this morning is Pamela Holmes. Pamela is a physiotherapist at Prime Meridian Physiotherapy. She specializes in a few techniques that I'm not familiar with, so I'm very excited to hear this talk especially. So she specializes in craniosacral and visceral therapy, and also incorporating significant patient education, and as well as yoga, meditation, and energy work into her practice. And she will describe how these lesser-known therapies can be used to treat pain. Let's welcome Pamela.
Hello. Thanks very much for having me. I'm a private practice physiotherapist at Prime Meridian Physiotherapy. I am Prime Meridian Physiotherapy. I'm a sole practice. And I've been practicing for 30 years. And I'm passionate about learning more about the care of people with persistent pain, both through courses and listening to my clients. Listening to our clients, I think, is a real gift, because many of them do come in and feel they haven't been listened to. I've completed a number of courses, including a pain care yoga certification with Neil Pearson, a well-known Canadian physiotherapist and pain educator who uses the many aspects of yoga to embody the pain science principles. I attended the inaugural San Diego Pain Summit in 2015, where one of the world's leading pain researchers and one of my heroes, Lorimer Mosley, presented. And I'm shortly going to go to Yellowknife to take the course Reconciling Biomechanics with Pain Science in Yellowknife, and that's next weekend with Greg Lehman. And I hope to learn about how the hospital in Yellowknife is working with their chronic pain clients. And they have quite a different system from what I understand. And I'm also undertaking the somatic experiencing training with a number of local folks here. Is there anybody here that's taking the training, somatic experiencing? Nobody? Because it's about 20 people there from all over the territory, and they're going to be a wonderful resource for addictions, trauma, and pain. So I primarily offer one-to-one sessions with people. However, I realize that's not affordable or accessible for everyone. And so I'm actually not going to talk about what I do one-on-one. As well, the more complex clients do require multidisciplinary support, which they may not be able to access, and the lack of which may retard their progress. So I have offered courses to small groups teaching self-management skills, a 6-week course based on Neil Pearson's scientific model of recovery, incorporating knowledge, breath, mindful awareness, and graded movement. More recently, I've used a 3-hour afternoon workshop format. The classroom setting is a cost-efficient delivery and also a good environment for support, as many people with persistent pain report being stigmatized and not understood or believed, including at work and even within their own family. They appreciate being in an environment where everyone gets it. A couple of healthcare practitioners have also attended. Course assessments by participants were quite positive, as people felt empowered and supported. They were excited to learn what they could do for themselves. However, it can be a long road to recovery, and ongoing support is needed. I did advertise on ArtsNet and most recently received an inquiry from Dawson wondering if this course could be made available there. I've not traveled to the communities, but I can certainly envision a weekend program that could be offered in the communities to be followed up with individual or group Skype sessions. I'm going to persistent pain and chronic pain will be used interchangeably in this presentation. Chronic pain is a familiar but a really loaded term with many associated connotations such as hopelessness, inability to improve, a forever condition. Persistent pain, like chronic pain, is pain that has persisted beyond the usual course of healing, but hopefully without the baggage of chronic pain, and can be associated with the potential for change. Pain literacy is a term I have recently encountered that I feel is a much better descriptor than pain science. It is important to recognize that pain is an output of the brain from multiple inputs, over one of which may or may not be tissue damage. And that might be a different way of talking about Jonathan's biopsychosocial. So I'm just going to repeat that, because if you only take one thing away, it's just getting away from that biomechanical model. It's important to recognize that pain is an output of the brain from multiple inputs, one of which may or may not be tissue damage. The tissue damage may no longer be there, and people will still have persistent pain. Many changes take place within the physiology of the nervous system, causing it to be hypervigilant in chronic pain. The sympathetic nervous system is on high alert all the time. Chronic pain could be thought of as the dark side of neuroplasticity. But we can also use this plasticity of the nervous system to recover. If this is not familiar information for you, I urge you to increase your pain literacy. I do have several copies of Neil Pearson's Understanding Pain, Live Well Again booklet. If people are interested, it's a good patient education tool, but also a good starting place for healthcare providers. I submitted a proposal to the Yukon Innovation Prize, which had the theme of health and wellness this year. I thought I would share some of the ideas from it with you today. The goal of my innovation proposal was a holistic, persistent pain strategy that is not only client-centered, but client-directed. This strategy would employ up-to-date pain science. It will encourage and utilize the knowledge and abilities of our healthcare providers beyond medication and empower the people with pain to regain optimal well-being. It could include the development of a pain navigator website that is Yukon-centric to ensure people with persistent pain can navigate the complicated maze of care, education, and support required to regain optimal health in the most efficient and cost-effective manner for themselves and the healthcare system. Chronic pain care is complex. Recent research and work by Butler, Mosley, and Pearson, and many others has made care of persistent pain much more hopeful. It requires a huge paradigm shift away from a strictly biomechanical approach that we have been so steeped in the part of healthcare practitioners. We need to recognize the role of the hypervigilant nervous system and the need to encourage pain that is a positive neurological experience. The opioid epidemic is an indication we've not been doing a good job at engaging all the options. Recognizing the current reality that people are frequently consulting the internet for healthcare solutions with sometimes dubious links, and that many people do not have a family physician, or their family physician may not be fully up to date on local resources or latest pain science research, the main target audience would be those most invested, Yukoners affected by pain. The website would provide reliable, up-to-date information, links to useful apps, appropriate resources, and programs in the community or online, and access to a network of informed healthcare practitioners, both public and private, that could form a virtual multidisciplinary pain clinic. A peer support network supported through the website would also be very useful, as chronic pain is also very isolating. So it's critically important that to get up-to-date pain care information to the people that are suffering from persistent pain. They need to know that with proper education and treatment approaches, they can change their lives for the better. People in the communities that already have limited healthcare resources would benefit greatly to have access to this information. And the pain literacy of healthcare providers is also so important because you can't really provide good pain care if you don't understand how chronic pain works. The Yukon has many people and programs in both public and private sectors doing excellent work. And just at our table before the presentation, we were talking about there is lots of good programs here, but we don't always know what they are. Often it's only through word of mouth that connections are made. For example, one of my clients recently accessed the anxiety education program through mental health on Hospital Road. It has been of significant benefit. Anxiety is often an issue for people with pain, either as a result of pain or as a pre-existing condition. I was not aware of this program and only heard about it through the client who accessed it. So I proposed for my innovation proposal that we have small pain summits in 2 or 3 of the smaller communities, and that would give an option to offer education as well two-way dialogue to discuss obstacles, needs, local resources, and solutions with clients. And then have a pain summit in Whitehorse, and also just research what the pain care resources are throughout the territory, both public and private, to build this informed virtual pain program. So I guess my 2 takeaways, I'll just sum up. I'm getting the sign. Just really improving the pain literacy or the pain knowledge of the healthcare providers and, and making it available to the people that have chronic pain are certainly the ones most interested in doing the research from what I've seen. And movement that's a positive neurological experience. So I find you don't necessarily have to have specific stretches and strengthening. You need exercise that feels safe and that calms the nervous system. Neil Pearson suggests we see opioids as movement pills rather than pain pills. Use them with the focus to get people moving rather than just decreasing pain. Thank you.
All right, that was great. So I think we're going to open it up to questions right away. So if you have a question directed for a particular panelist, please just address them when you ask your question. But if it's a bit more general, maybe the panelists can decide who wants to respond, if that's okay. So Sean in the front here has a question.
Good morning, Hawkins again. Thank you. Wonderful presentations. Might I boldly suggest that next year you have a registered massage therapist at your table as well. Kristy and Jonathan, you both spoke to acupuncture. In a previous life on an assertive community treatment team, I had access to a therapist that did acupuncture in the ears for addictions. I wonder if anybody could speak to that. Thank you.
Is this on? Acupuncture for the ear, that's more along the lines of traditional Chinese medicine acupuncture. So the acupuncture that I practice is more along the contemporary medical approach. So we're more focused on affecting the muscles and the nerves versus going the more traditional Chinese approach, which has, I'm not sure I can appropriately address that, but it is a more whole body and has to do more with meridians and energy flow. So a slightly different approach.
That being said, that can be very effective for pain. The TCM approach as well. We just don't know a lot about it because that's not our focus.
Emily?
Hi. So the clients that I'm working with are marginalized injection drug users, perhaps HIV, Hep C positive, or at severe risk of becoming. And obviously, cost is an issue, so that is a huge barrier for access. At Blood Ties, we had a very successful program where we had a naturopath who was at Blood Ties for years and years and years, and she provided wonderful acupuncture and massage therapy. And the fact of the matter is that we have clients that don't experience touch ever in their lives, and so to experience some kind of touch is really therapeutic. The one barrier that we've come across time and time again, and we didn't experience this with our naturopath, and we very rarely experience this with other practitioners that we bring in. But when we bring in massage therapists or chiropractors or physiotherapists, they're often asking our clients to disclose whether they're HIV or Hep C positive from the get-go. And our clients are so overly stigmatized anyways, that is just, it's unbearable for them. And unfortunately, we've had people who are not willing to waive that from the get-go. And I'm just wondering what your thoughts are on that.
I actually just wanted to talk a little bit about, this is a bit of a side topic, so hopefully someone else can more directly answer your question, as I'm not really familiar with the program that you're talking about. But one of the things that I didn't have time to address was the access of that particular population. And one thing that I'm finding in the hospital is that we actually don't see those patients. And so even though there's no problem with funding, because it's free, what we're finding is that when this patient population is referred to us, and we call them and we say, you have an appointment for June 12th at 1:30 p.m., the chances of that person showing up is 2%. And so they may show up and then they don't show up for their next appointment. And if you pull that patient's files, you will see a history of referrals and no-shows. And so accessing that patient population and doing it well, because you also bring up the issue of, the stigmatization and how we potentially are making that patient feel that they can't connect with us or are afraid of us or don't even want to engage, we have the trouble of not even able to get the patient in the door. So there's a lot of access issues around this patient population, which I'd be excited to hear people's ideas of how we can do that better. Yeah, and I'd be excited to hear your comments on that. Because it's funny, when I was first asked to do this talk, I was saying, when we actually see these patients mainly is in inpatients in the hospital after they've broken a leg from falling or they've been beaten up. That's when we see them, and we rarely, if ever, see them in outpatients because they don't come to the appointment. And I'm actually not sure how to address that, and I'm super excited to hear your ideas. And I think our staff would be excited to hear comments like, these are the ways that you can really just, upfront impede the relationship by asking these questions. And I think, we're very open to that dialogue for sure. I hope that helped.
I just wanted to follow up quickly. So I'm with Blood Ties for Direction Center, and we're constantly trying to get people to come. We have access to those clients. Those clients are in our drop-in center daily, and they trust us, and we are constantly approaching physiotherapists, chiropractors, massage therapists to come in and work with our clients because that's where they are. The old jargony harm reduction phrase, meet them where they're at, and it's true. So I think that's what it is. It's really engaging with that population where they are, because expecting them to go for appointments, yeah, you're right, like, it's near to impossible.
Just in terms of your comment about asking someone what their health status is, whatever it is. So we've sort of been trained, it's sort of been indoctrinated into us to ask that question, just because if someone's taking a certain medication, it can affect the outcome, it can affect musculoskeletal pain. It's nice to know. Someone who's needles, myself, I'd like to know if someone's HIV positive, because I might decide if I'm feeling tired that day, I may not needle them, because if I stick a needle into them and then I stick it into myself, then I'm putting myself at risk. So it's also a safety issue. But that being said, people we know don't always tell us, so we also assume that everyone's HIV positive, right? So we use that. So it's not something that we require people to do, but it helps from our perspective. Just the other comment, I just asked Jonathan, I said, have you been approached by those guys? Because I haven't been. So my suggestion to you is just do a Google search of every clinic in town and send them something, or call them up, or yeah.
She's on it already, I think.
I missed it.
I can see her on her phone right now in the back. Okay, we have another question here.
Actually, I just want to make a comment about acupuncture. So Jim and I came to Canada at Whitehorse 26 years ago. We came as an acupuncturist, invited by Dr. Brownigan, who believed in acupuncture. And I believe that time when we just came, we started with ear acupressure because we didn't get a Canadian any board exam, so we thought we shouldn't insert the needle. So actually, just make story short, I was a family physician. I was a physician in China, and in China I have Western medicine, Chinese medicine, herbal, medication, investigation, every perspective information before I treating patient. So do Jim. But when we came here with language limitation, with two limitation, we didn't know where to get needles, we didn't know where to get herbals. So, but we started with both our hands, just acupressure and ear acupressure too. So we started with, it's Wangbu Liu Xing, it's a seed. With the ear have 52 points. Most related to cranial nerve and also lots, much closer to the lymph drainage system. So it's worked very well with pain, with functioning disorders such as insomnia, tinnitus, many of pain like menstrual pain, even for giving birth delivery, like for that pain. So we started with that, and that's almost like advertising for us too, because after people see us, they have a little mark on the ears, and they would ask what that is, and they told them about these two Chinese doctors here. So, and so do cupping suction is kind of a little mark. When people go to swim, they see, oh, what's a bruise? And they say, at least two acupuncturists. So that's we started our practice. Ear acupressure in China has been very well used, although it is a branch of a traditional Chinese medicine, but has way more of scientific proof for ear acupressure, and they require way less trainings than the body acupuncture because it's a less risk to injure the body and more effective, especially with ear acupressure because the ear cartilage. So if you put a seed, the pressure is create more effect than really the puncture of needles. And people most can self-management. Once you put the pressure, you can leave there. If you don't wash it, and it's usually, no, even you wash it, when you withdraw it, it can leave 7 days. So you can do 4 or 5 times a day or 3-4 times a day to pressure the point itself. It's very well working. That's how saved us. Get all my clients, our clients supported us when Canadian government immigration considered we are not qualified workers because we are foreign worker came. Our income didn't meet the minimum Canadian requirement. They said, your job not needed. So they deported us, and I think our clients supported us, so we stayed. By the way, acupuncture is existing for over 5,000 years. It's not based on science, but Western culture is based on science. I remember when I came here, everything upside down. Acupuncture to us is a tradition, is the way of healing, but to here it's new. I remember one of my patients, after seeing his family doctor, came back, talked the feedback. He asked about his family doctor, what he think about his acupuncture. And his doctor, after all the detail, and said, I can't believe you allowed somebody stick needle on your leg when you have nothing wrong at your leg, when you come for a headache. And that's the culture, that's the education, that's all 26 years ago, like information book and internet is not existing. So that's healing work is foreign to North America. And mind-body connection is probably existing in First Nation healing traditions. The nature is our Mother Earth is provide all the healings we need, utilizing herbal food, mind, body. But that is in Western scientific world, it's just not the way of healing. So that's why Jim and I was well accepted by First Nation culture. And acupuncture has so much theories. I want to spend all your time. So do the ear acupressure. I just want to make a comment. Thanks.
Thank you.
Hello, I'm Elisa Avoy. I'm an outreach nurse. I'm not good at talking in front of people, so I apologize. I'm just having maybe political questions regarding the chronic pain. I agree, the outpatient physio, it's overwhelming dealing with surgeries, and so I'm just wondering what does it take for lobbying to have people dealing with chronic pain accessing physio, acupuncture, naturopath, and having a pain clinic maybe aside to Taiga clinic, or all these outreach people. I work for the Kwanlindon First Nation. I work at the outreach van. I recently started at the jail as well as a nurse. And there's such a big gap for these people to navigate through the government system. And so having a centralized pain clinic would be really good. And accessing physio, chiropractor, naturopath, diet at that clinic is so important. And also prescribing opioids versus, like the cost for that versus paying for a physio visit, like we have to. I'm sure it's way less money. And also another thing for communities, like using home support workers, SIL workers, more outreach workers to delegate the exercise. You know, like people, when you go in the communities and you want people to be on an exercise program, you can delegate these exercise to home support workers that are in communities, or create more SIL workers, outreach workers that could assist with that. And one last question that we're not talking at this conference, but also I'm curious about marijuana and pain control. And I know opioids versus marijuana prescription. I'm always shocked that opioids get prescribed so easily, and then pot is kind of a big no-no. I'm not a big pothead. I don't want to come out like that. But I'm just like, opioids do harm people. Like I know a lot of people coming out of surgery, young people addicted to tea trees, then go on with the oxycodone, then shooting. Like it's happening daily. So yeah, I'd like to hear more about that too. Thank you. Sorry for my wobbly voice.
I try not to monopolize this, so I'm just going to say one really short thing. I think it's easy to think and get stuck in that idea that we need a centralized location to offer pain services. And I think we also can get stuck on the idea that we know what people need to treat their pain. So I really like Pam's idea of allowing the sort of virtual clinic. I think it's unrealistic to think that you can take all of the people who provide pain services in the Yukon and put them in one space, mainly because a lot of them have their own practices and it's just not going to happen. The second thing is I think it's something that we can't assume that we know what somebody needs. Sumay just brought up a really good example of how something that's mainstream in China is viewed as alternative here. So we can't assume that everybody needs chiropractic, physiotherapy, massage therapy. We can't assume that we know what they need. We have some ideas, but there's a large component of chronic pain that I tell patients there's this area that only you can figure out. It's going to help you. What is that thing that's going to help you deal with the stress and your own response to pain? And it's very individual. So I just want to make that comment that I think we have to think a little bit outside the box when we're thinking of funding and programs and all the rest of it.
I would actually say probably a quite different view. I think it might not be a bad idea if we did have a type of pain clinic where you have a bunch of professionals in one place where at least you are getting a lot more communication between the medical doctors and the physios and the chiropractors and the acupuncturists, and that way you do have a place where everyone is together and working for that one common goal of the patient. So different views, but for sure both are valid.
I just wanted to comment on the ease of prescribing opioids. I've actually had a very different experience, especially in the recent history now in Whitehorse around acute pain, and a fairly significant fear of prescribing opioids that is coming up around acute pain, and having patients come in post-operatively with pain that isn't well managed, where you can really see a hesitance, and a fully understood hesitance to prescribe these medications where there is a very acute post-operative issue that needs medication. So I think we just have to be careful, and somebody did mention, and I think it was you actually who mentioned that there is a place for this, And so where do we, just not making sure that we don't swing from one extreme to the other, that we make sure that when there's really an acute need, that it's being given, because my concern is in some of these patients, if their pain isn't being managed by the physician, where do they go? And we certainly have patients coming into physio with some pretty severe injuries, who are, in the fetal position when they come in, unable to talk, crying. And, one of the problems that we have in speaking with the issue of trying to get everybody in one place is that we are quite isolated. And even we're in the Thompson Center, we're not connected to the hospital. We actually call 911 when somebody codes. We're not part of the hospital. We send people to emerge when they don't have a family physician, trying to get them pain medication. So our access to trying to get medications for patients who really are in a dire situation is difficult, and that's one of the barriers that we face. So there's sort of, I really do see the value in having people centralized dealing with pain in one location, because sometimes that communication when you're physically isolated can be difficult.
Just from my perspective, I think, your people have difficulty accessing proper care, but I think a lot of people have difficulty accessing proper care. Just finding out what the resources is really difficult, and even motivated people are really struggling. I saw someone on Whitehorse buy and sell, asking for help because they just didn't know where to go next. So we do need some kind of coordination. As I said, we have lots of wonderful resources here, but we need some kind of coordination. And the other thing is, recovering from chronic pain, persistent pain, is really hard work. And people that are, well educated and have all the resources at hand, it's still really hard work for them. So it's not something that you can go in and spend an hour with a physio and once a week and you're going to get better. You have to have tools that you're going to be doing every day and practicing every day. So it's, Pearson sometimes, it's like training for an Olympic event. Chronic pain, recovering from chronic pain is really hard work. And I don't want to say these techniques are magical, but there's something people can do every day and they have to do every day to get that nervous system calmed down.
I think in the interest of time, what do you guys think? Sure, yeah.
Hi, I'm Emily. I'm the manager of the Chronic Condition Support Program with Yukon Government. Before I get to my question, I just wanted to say we are the program that Leslie referred to that recently got permanently funded by Yukon Government for chronic condition support. We're very, very excited. Just wanted to clarify as well, though, we were on term-based funding, federally funded for about 10 years, and that was condition-specific funding, COPD, diabetes, but Yukon Government has permanently funded it. We've inherited processes and programming around those condition-specific, but absolutely we recognize chronic pain, other symptoms of chronic conditions, and really trying to work towards symptom support around chronic conditions as opposed to condition-specific programming. So really excited moving forward and to be here and have those conversations. So stay tuned. We got some exciting things coming in this area. My question is really for any of you here. We talk about chronic pain clinics, some ideas around what that could look like, but who, you're all part of here with in your respective professions. I'm wondering if there's anyone we haven't mentioned here today yet that should be part of the conversation, any professions or anyone, if we were to have like a chronic pain clinic or collaborative model, what that would look like, who should be at the table that maybe we haven't mentioned.
Nursing. I really do think that non-pharmacological interventions do frequently, especially with severe pain, need to go hand in hand with medications. The medications need to be, I think even having a conversation about the importance of the interval between the pills that you take and keeping things under control and having a really strong education with the patient, with a nurse around how to be best taking those medications to keep things under control. And one thing that I struggle with as a physiotherapist is that, you know, we do actually get quite a bit of education around this, but it does feel quite out of scope, and realistically it's out of scope. And so you don't really want to have these in-depth discussions about how someone should be taking their medications. And so I do think that a nurse needs to be sitting at the table, or a doctor, one of the two, but somebody who can speak to the medication point of it.
From the guidelines that were just released, lots of other professions, so getting someone to work with cognitive behavioral therapy, kinesiologists, psychologists, all those professions should definitely be added as well.
I had chronic pain for 2 years, and it was stress related. And I went through the medical system, and it was, I don't know, a doctor would probably be able to tell anyone in the audience what I had, but it was essentially, it was trauma related, and my nervous system was in hyperdrive. So what worked for me was things like yoga, meditation, on Sunday going to my favorite gelato shop and taking care of my inner child. So things that are sort of out there. But I think that it's important to acknowledge that when you're dealing with pain, when you're dealing with stress, when you're dealing with things that are a result from trauma, the alternative world really does offer something to people. So I'd like to see people from yoga, meditation, sume, as she mentioned, traditional Chinese medicine, those things that we tend to think we don't really think of when we first think of things like that.
Okay, great. Dr. Hanley, did you have anything to add? You were standing. You okay?
Sorry. So I'm Melissa Leluc. I work with the Chronic Condition Support Program. I'm the exercise specialist for that program. So I'm also a part of the lead on getting our chronic condition support self-management workshop back and running, and looking at how do we give patient education and how do we provide support to patients to get through the process of self-management. And I think that keeps coming up. We have great professionals, great programs within the community. We have to get patients there. We also have to connect them there. We have to support them. They can go to a physio, a chiro, but if they're not doing the homework, it's not going to benefit them. And it's frustrating, I think, for health professionals that you continue to return to me without doing any of the work. And that's where patients, I think, really need the most support. And I think that being creative in how we do those models has to be up there. It doesn't have to be our physiotherapists and our chiros or our pharmacists at that level, even our nurses. Sometimes we need a different level of support care for patients, so that when the professionals say, do these things and take these pills, and it's just somebody there to help them through the process, help them through those failures, help them realize that that's a normal process. And I think that our program is working in collaboration with many of the other providers, trying to brainstorm on ways to do that. But I think what I keep hearing too is that movement is so important to all of it, to mental health, to disease prevention, chronic pain prevention and management is movement. So we just got to get people moving. So it's not just in this level, it's also in the recreational side too. Like you were just mentioning, like getting the other providers involved. Like there's many programs available. It's like, how do we get people there? How do we get them access as well? Because finances are an issue and everything seems to cost a lot of money. And so I think society is, in a small community like here and in the Yukon, I can't seem to wrap my head why we can't make these changes happen with such a small population. So I think as a group of working people, it's getting people moving and supporting them to get them there, and you know, keep connecting. And this is a great opportunity to connect all those pieces and to learn about all those programs and keep going with that. So that was just my thing, is that patients need support. It's not that there's a lack of professionals.
That's great.
Yeah, just I agree with everything you say, Melissa, and I really think the classroom setting doing group sessions, it's cost effective, but it inspires people when you come to a class and that person over there has really improved. And like I had someone come back to a class and say, I'm 100% better from the first class. And all she did was practice the breathing every night. And she slept. And just having slept that whole night, and or having slept all week just improved her condition. But I also, so the classroom or group sessions, I think, is really cost effective and motivating for people. So it can be peer-to-peer support as well. And I also want to say that just as a private person trying to run these classes, like I haven't run them for the last 8 months or so, because it's just too much for me to try and do on my own. So I'm hoping there might be support for more kind of classes like that, or organizing them anyways.
Great. Thank you, everyone, for the lively discussion. And if you could join me in thanking our panelists for this morning's talk.